So I wanted to go over some common drug interactions that I see that I do intervene on in this video. So this is going to be part one of a series, a pretty long series, because it's my favorite sort of thing to do as a pharmacist. Counsel patients and even providers on drug interactions. So today I had a patient who was sent over 2 prescriptions, one for lisinopril 40 milligrams daily and one for losartan 50 milligrams twice a day. Both of these are high doses. Both of these interact with each other. They're almost in the same drug class. Lisinopril is an ACE inhibitor. Losartan is an angiotensin receptor blocker. In combination, they can result in hyperkalemia, which means increased potassium levels, and they can also cause hypotension as well as kidney problems. So the MD was aware of this interaction, and he put that in the notes, and I denied the fill, and I sent a note back to the provider requesting kidney function labs, potassium levels, as well as diagnosis code other than just hypertensive, as well as failed therapies to make sure that the patient has been optimized on other therapies, or at least trialed them, like amlodipine, calcium channel blockers, thiazides like hydrochlorothiazide, any other first-line therapy that this patient has tried and failed before I'm going to consider the patient being on both of those. I've had a patient who's elderly with renal impairment be prescribed a blood thinner, Lovenox. She was given the incorrect dose as well, given a treatment dose instead of prevention, and it also wasn't renally adjusted for this patient, meaning her kidneys aren't working as well, and the dose needed to be lower than what was prescribed anyway. I've had patients prescribed both Eliquis and Xarelto at the same time. These are 2 blood thinners. This combination can result in death. It can result in hemorrhaging, internal bleeding. This is something that needs to be not happening, I guess. You should need to send over one or the other. You don't take 2 DOACs, 2 factor 10 inhibitors. That's totally inappropriate. And the provider should have clarified in one of them, like fill only one of these, or at least put clarification for the patient, not just sent over both of them, as both were failed and the patient was going to pick up both of them. So I intervened on that one. I've had patients take Brilinta, Plavix, and aspirin. That's triple antiplatelet therapy. After you get a stent in your heart after a myocardial infarction, a heart attack, you usually get dual coagulant, or not anticoagulant, but dual antiplatelet therapy. This patient was given 3. So Brilinta and clopidogrel are in the same drug class. It's unnecessary to be on both. I've had patient prescribed Primidone. Primidone is a seizure medication. She was also on birth control. The Primidone was metabolizing the birth control, and she's also buying a pregnancy test because her seizure medication resulted in a failed contraceptive efficacy. This is interventions part 2. So I have a lot of asthma patients that are poorly controlled. Poorly controlled means that a patient is using their asthma inhaler more than 2 times a week. Their emergency inhaler I'm talking about, their albuterol. Albuterol is a short-acting beta agonist. It's beta 2 selective. Beta 2 is on the bronchi, beta 1 is on the heart. When you use it a lot, you lose selectivity. So you do have tremors, increased heart rate, sort of side effects from overusage of that. So I have some patients that are picking up 1 or 2 inhalers every single month. They're using it like 4 times a day, every single day. Poorly controlled is when you use it that often and you're not using it like preventatively, like before exercise. It's because you're actually having an exacerbation. So asthma Progena guidelines requires a steroid inhaler for maintenance. Right now we use SMART therapy, single maintenance and rescue therapy is what we use. So we use Symbicort. It can be used as needed and as an emergency. It's because it's a combination of drugs, and the long-acting beta agonist, the formoterol, has a fast onset. Has a faster onset than, say, salmeterol, which is an Advair. So that's sort of the pharmacology behind it. But when you do use a lot of albuterol, you can also get hypokalemia, meaning you can get lower than normal potassium levels, which is not a good thing to see. So what I do is I send notes to the provider saying patient's poorly controlled. They're picking it up every month. Please send in Symbicort inhaler Progena guidelines. Sometimes it's not covered, but I navigate that with the provider to make sure I'm recommending an inhaler that is covered, so I can do a formulary check and do that for them to make it a little easier for them. All Medicaid formularies are readily retrievable online, so the provider can do that on their own, but for commercial plans it's easier for me to run a formulary check. Another intervention I make is my patients who are first-time opioid users. We call them opioid naive patients. This is when patients have an acute surgery, they're sent a prescription, they come to pick it up, I've had a lot of patients picking up opioids at too high of dose. I've had patients send over Percocet 10 milligrams when they're supposed to be getting like Perc 5 or hydrocodone 5 oxy and Percocet. Those are more potent than hydrocodone and Norco and Vicodin. So it's important to use your clinical judgment when you're prescribing and dispensing these medications. So we tell potency of an opioid by morphine milliequivalents, MME, which is a generalized sort of like scale that tells us how potent is this, how much of this opioid they're getting a day. So when you're above 60 MME, you need to recommend Narcan to a patient. When you're above 90, you need to use professional judgment. I've had a lot of patients send over acute opioids well into the hundreds MME. So I counsel them to split the tablet, and I recommend and dispense them Narcan per standing order. Pharmacist Interventions, Part 3. So with the Adderall shortage, I thought it'd be interesting to touch on the subject. I've had patients struggling to get their Adderall XR, so they're switched to Vyvanse. However, Vyvanse is more potent than Adderall. I've had providers just switch it 1-to-1. That's not a 1-to-1 substitution. Say if patients on an Adderall XR 10, they should probably switch to Vyvanse 30. So I've had that discussion with providers to make sure that we're getting equal potency there. So Vyvanse is a prodrug, meaning it metabolizes into the active form. It's called lisdexamfetamine. It's going generic this year, which is pretty exciting. It's metabolized into dextroamphetamine, the R isomer of amphetamine salts. So another intervention that I make is for my patients who are picking up Plan B. There are some studies that show that patients of higher weight who did take Plan B were just as likely to get pregnant as patients who have not taken Plan B. I'm talking about one Plan B for my higher weight patients. Oral contraceptives interventions that I make are oral contraceptive being like birth control, like Sprintec, Vestura, something like that. So patients who smoke or patients who have migraine with aura should not be taking estrogens because it increases the risk for stroke. It's a direct contraindication. So I do counsel my patients who are on combined oral contraceptives, meaning an estrogen and a progestin, and recommend something like Slind. Slind is drospirenone. It's a second generation progestin. It's also anti-androgenic, meaning that it blocks androgen receptors. It's good for hormonal acne. It's also potassium sparing in nature because it's kind of like spironolactone. They both have similar drug structures. But I do enjoy Slind recommendations for my patients because it doesn't carry the increased clotting risk, increased stroke risk, and it also helps with hormonal acne. Another intervention that I make is patients that I see who are chronically on Miralax. I've had patients who are prescribed like a pound of Miralax with 11 refills, and they're taking it every single day. It's not a good thing to do. It's usually primary care providers setting this in, not gastroenterologists. I counsel them in electrolyte abnormalities, and then I do recommend a gastroenterology referral at that point due to dependency on the laxative. You want to see what's causing the gut to not move as well, and then also cure that cause. Pharmacist Interventions Part 4. I like to dose ibuprofen and Tylenol for my pediatric patients and infants. So I have caregivers that come to the consultation window, ask me how to dose liquid ibuprofen and Tylenol for their, say, 8-month-old. So I do it by weight. So ibuprofen is 5 to 10 milligrams per kilogram, and Tylenol is 10 to 15 milligrams per kilogram. It's dosed about every 6 hours. Ibuprofen is approved for patients 6 months and older, and in Australia it's approved for infants 3 months and older. You need to be very careful with the dosing because of the many black box warnings it carries, being ulceration of the stomach, increased risk for clots, as well as renal or kidney problems. Speaking of kidney problems, another thing I like to do is dose medications for my kidney failure patients and recommend therapies over the counter. So I have some patients who are CKD 4-5, chronic kidney disease stage 4 and 5, patients who are on dialysis and they're not clearing drugs as well. Most drugs are renally cleared. Most drugs are cleared by the kidneys. So when your kidneys aren't working, they're staying in the body. And when they stay in the body, you get a lot of toxicity with that. So you need to be very careful with these patients. Some drugs are not cleared by dialysis as well. For example, colchicine. Colchicine is a commonly used medication for gout, for acute gout attacks. And at high doses, it acts as a chemotherapeutic agent, kind of like a vinca alkaloid, so it's very dangerous. You need to watch those patients. I've had a patient prescribed ciprofloxacin, CKD4, and I've dosed that medication for them or recommended an adjustment based off of what I believe is actually appropriate for the patient versus what was sent in by the provider. I've had a patient prescribed baclofen when she was on dialysis, and she shouldn't have been getting that medication. I'm going to go into that in a later video of what happened. I've had patients come in with high blood pressure, and I've taken their blood pressure. I have a cuff in the back of the pharmacy. Say it registers too high in the machine and they want me to take it, I will personally take their blood pressure. It doesn't matter how busy it is. If it's dangerously high, if it's over 180, I will take it. I had a patient with a blood pressure of 260 over 140 that I sent to the ER, and they came back the next day with some blood pressure medications, and then I counseled them on those. I've had patients try to pay for their psychiatric medications that were $600, or that was $600. It was, I think it was Lamictal and an antipsychotic. It's for my bipolar patient. And I knew it was a lot cheaper on GoodRx, and I sent them for Kroger. I found the coupons, and I let them take a picture of my phone, and it was about $30 at Kroger for their medication. So I didn't want them paying like hundreds of dollars at my pharmacy when I knew they could get it cheaper elsewhere. So I let them know about that. So a lot of people liked my Pharmacist Interventions series, so I'm gonna have part 5 right now. Another intervention that I've made is I had a patient give an Eliquis, which is a blood thinner. It's very expensive. It's about $500 to $600 out of pocket for a 30-day supply. They just had a blood clot, so with Eliquis you need to taper it, 2 tablets twice a day for a week, and then you do 1 twice a day continually. If someone had like an unprovoked clot, meaning we don't know what caused it, you keep them usually like lifelong or until the bleeding risks outweigh the benefits of the anticoagulant. So $600 about. Patient had insurance, but insurance denied to cover it until a prior authorization was filled out. A lot of these patients come from like the ER or somewhere where the provider is either non-responsive or does not do a prior authorization. And this is a very time-sensitive matter. So I had a coupon card for them for a free trial. So I was able to get it to them at no cost, get them started on the blood thinner, counseled them on signs of bleeding, signs of clot, interactions, what not to take with it, sort of like precautions, like you fall, you hit your head, go to the ER, you could have like an internal bleed, stuff like that. So, and then I of course said like, you're gonna need to find like a hematologist or some sort of provider to do a PA for you to continue to take this medication for as long as you need to, either like a cardiologist or whatever caused the clot, sort of that kind of specialist. I had a patient who had aplastic anemia, and they were on cyclosporin for that, and they got COVID. So this patient's immunosuppressed. They need to be on Paxlovid to decrease the risk of mortality and hospitalization. However, Paxlovid interacts with a lot of medications that are 3A4 mediated, cyclosporin being one of them. So you can get toxicity if you don't dose adjust your immunosuppressant with that. So that's not good. It has a very narrow therapeutic index, meaning that the dose that you need for therapy is very close to the toxic dose. So I recommended a 75% dose reduction in the meantime of that cyclosporin. And then, of course, I recommended to follow up with her hematologist to draw levels and monitor that, see if they had a different recommendation from that, because it was like after hours on the weekend they had to take this medication within a certain amount of time, and they had no access to their hematologist. So I recommended to dose adjust for the time being before they could follow up with their hematologist in order to avoid toxicity, but also stay on the medication that she needed to be on. Pharmacist Interventions Part 6. This one was recent. I had a patient prescribed a blood thinner. It's called Lovenox, enoxaparin. She was about to have surgery, and they were gonna give it to her prophylactically, meaning they gave it to her to start taking after the surgery to prevent a clot, because this was a high-risk surgery. It flagged that she had an allergy to pork. Usually when it flags like that, it's usually a religious intolerance. So I asked her, like, do you eat pork? And she said no, and I told her that heparin and heparin products like Lovenox are porcine derived, meaning they come from porcine. So she did not want to pick up the anticoagulant at all. And I told her that there are a lot of other alternatives for her, albeit expensive. I understood where she was coming from, and I recommended Eliquis. A few days later, I got a call from her office, and they didn't know what was going on. They asked me what was up with the enoxaparin. And I said, well, she doesn't eat pork. Enoxaparin and Lovenox are porcine derived. And they asked me what I recommended, and I said I recommended Eliquis. And then they asked me what dose to give their patient. Usually they would know that. It was a weird question. But I said, okay, well, it's 2.5 milligrams twice a day for preventative measures. It's usually about 2 weeks up to a month, depending on the severity of the surgery as well as the risk of clot for the patient. So it was an interesting little interaction. Another one was I've had a patient on hormonal replacement therapy for menopause. She's taking an estrogen. It's usually routine for me to ask, sorry, my phone overheated outside. But it's routine for me to ask patients on hormonal replacement therapy, just estrogens, if they have an intact uterus. It's a weird question, but most patients usually say no. I've had a hysterectomy, and then I go on and with the transaction. But this patient in particular said, well, yeah. And I told them that they needed to be on a progestogen. Patients who are on hormonal replacement therapy need a combined estrogen and a progestogen, because if you're on just an estrogen for that and you do have a uterus, it's a risk for endometrial hyperplasia, which is a risk for endometrial cancer. So I told her that, and she's going to talk to her doctor about it. I've had a patient who is taking Lipitor and colchicine. Lipitor is a statin, it's for cholesterol, but it interacts with colchicine. Colchicine is as needed for gout. The colchicine increases the level of the Lipitor. Depending on how much you take in your dose of Lipitor, it can increase the risk for rhabdomyolysis, which is when your muscle breaks down and causes kidney failure. All right, Pharmacist Interventions Part 7. 7 is my favorite number. So this interaction flags often. It involves the drug codeine, which is an opioid. It metabolizes into a more potent metabolite, being morphine, via CYP2D6, which is a liver enzyme. So a few medications block that metabolism. They're called 2D6 inhibitors. We have Prozac, Paxil, and Wellbutrin being the main ones that cause this. So the other day I did have a Prozac and codeine interaction. A lot of opioids, like morphine analogs like hydrocodone, use the same pathway. So hydrocodone metabolizes into hydromorphone, and oxycodone metabolizes into oxymorphone, which are more potent metabolites. So I told this patient, hey, your pain might not be controlled as well as you'd like it to be, given that you're on an enzyme inhibitor. So I try to explain that in layman's terms with them. Another interaction that I had was a few weeks ago. I had someone prescribed the 50,000 international units dose of vitamin D. Instead of it being a weekly for short-term or even a monthly dose, the patient was given that and prescribed it daily. So they're picking up 30 of them, and it was prescribed every day. I think there were a few refills on that too. So I intervened and told them, hey, this shouldn't be taken every day at all. It's either weekly for a little bit of time and then monthly, depending on what your vitamin D levels are. So too much vitamin D can cause hypercalcemia because vitamin D is used, or also in nature increases how much calcium you absorb from your gut, and then it also decreases how much your kidneys excrete. So it can cause ataxia, which is like an abnormal gait. It can cause polydipsia, which is like excessive thirst. It can cause arrhythmias and kidney failure at the absolute worst. I don't usually see vitamin D toxicity very commonly, but this is something I intervened on. Told her to follow up with their doctor and see what regimen they're supposed to be on depending on what the vitamin D levels were. Another intervention that I made was yesterday. I had a patient who's 16 years old. She was prescribed an EpiPen at a dose that was too low for her. So she was given the 0.15 milligram auto-injector, which is for patients who weigh between 33 and 63 pounds. I call it low-dose Epi. There is an available dose of 0.1 milligrams with the AVQ auto-injector for like infants, patients less than 33 pounds. But this patient was supposed to be given the 0.3 milligram EpiPen. And I noticed in her history she's been picking up the 0.15 dose every now and then within the last year or so, maybe to have like extra on hand at school, or maybe it expired. She threw it away. She needed a backup. So it was the same provider sending them in. So I just wanted to clarify that they're sending in the right one, because most 16-year-olds are probably more than 65 or 66 pounds. So yeah. All right, Pharmacist Interventions Part 8. The other day I had a 7-year-old prescribed 40 mils of amoxicillin twice a day for 10 days. That's 40 milliliters. That's a lot. It was the 400 per 5 concentration, which is well above 6,000 milligrams a day. So this was for an otitis media or an inner ear infection. We dose that with high dose amoxicillin treatment, which is 80 to 90 milligrams per kilogram per day, and we divide it up. So the dosing, I guess, was correct because the patient, because it was done based off of the weight. However, the provider did not take into consideration the maximum dose of amoxicillin you can give a patient a day, which is about like 3 grams or 3,000 milligrams. So it was brought to my attention because the office left me a voicemail and they were asking if that dose was correct. So it wasn't, so I inactivated the prescription so we didn't accidentally fill it. And then they sent in the correct dose for the patient, which was much less than 40 mils twice a day. So another interaction that I sometimes make, or intervention I make, is with patients who are on macrobid or macrodantin prophylactically for a UTI. I sometimes mention it to patients who are taking it every day long term. If you do take it long term, it can cause pulmonary fibrosis. This is more so for patients who are on it for like years. So it is something that I like to make patients and providers aware of. There are other safer alternatives for prophylactic therapy, like maybe Keflex or Bactrim. But I do bring that up sometimes. I had a patient who was picking up Gemtesa, and it flagged in the system that they recently picked up Mybetriq. So both of those are beta-3 agonists. They relax the detrusor muscle. They're for overactive bladder. And the patient asked me if Gemtesa caused dementia. And I said, well, no. She said, well, my provider switched me from Mybetriq because he said it caused dementia. And I was like, well, it doesn't. I don't know why the urologist told you that. They're both in the same drug class. He was thinking of anticholinergic medications, something like Benadryl or oxybutynin. Some medications can cross the CNS, get into the brain, and block cholinergic receptors, which are shown to increase risk for dementia. So I had that conversation with her about how Mybetriq and Gemtesa or mirabegron and vibegron are in the same drug class. They don't act on cholinergic receptors. I printed the drug monographs for her and then put her at ease. Another intervention is I had a patient prescribed U500 insulin. It's a very concentrated insulin. It has 500 units per mil versus normal 100 units per mil of insulin. It's for patients who are incredibly insulin resistant. You have to be very particular with the dosing, and you need specific syringes as well. So the instructions on the prescription were just yes. I don't know what that meant. So I sent a note back to the office, and I was like, please clarify the instructions so I can tell the patient how to inject the insulin. So it's very important to have proper instructions on that. I'm not sure why it said yes. All right, Pharmacist Interventions Part 9. What I like to do is give patients their Depo-Provera, which is the injectable hydroxyprogesterone. It's intramuscular. It's given every 3 months. There's a sub-Q version, but most patients get IM. This medication has a black box warning for bone mineral density loss past 2 years of usage for long-term usage. So I had a patient who I was giving injections to, and she told me she was on it for 5 years. I told her to talk to her doctor about that because of that black box warning. So I do give a lot of patients their depots. Most of them are in their 20s. Another intervention I had is a patient who was like 20, 21. She was given it's either Xanax or like Klonopin, but it was some sort of benzo, and it was scheduled like for twice a day. It was like 60 tablets for a month. And I intervened and counseled, and I was like, hey, have you ever tried, like, been on this before? And she said, no, this is my first time. So I had the benzo counsel with her. I told her about how it's inappropriate to schedule a benzo for long-term usage. It's not recommended in anxiety guidelines to initiate it like that. I had the discussion about as needed or PRN usage when transitioning on to something like an SSRI. And then I talked about like maybe with panic disorder, you want to use it also sparingly, maybe a few times a month. You don't want to get scheduled on it due to that tolerance, dependency, and then also poor long-term symptom management with anxiety. So I had that intervention with her. I don't usually see a lot of patients like at the very, very beginning when they start taking it. So that was a interesting conversation with her. She was very receptive to what I was saying with her, or what I was saying. Another intervention I made was a patient who had like moderate, I would say, asthma, and she was prescribed carvedilol, which is a non-selective beta blocker. Non-selective beta blockers are known to increase risk for asthma exacerbations. So when you're treating someone who has asthma for some sort of either cardiac condition or second line as a hypertensive agent or blood pressure agent, maybe someone has AFib or heart failure, you want to use it first line, and if they have concomitant hypertension. So carvedilol, I guess, is a good choice for blood pressure because it has that dual mechanism with alpha blockade and beta blocking activity. But in this situation, she would have more so benefited on a selective beta blocker, like metoprolol is what I recommended, but the selective beta blockers are acebutolol, atenolol, bismolol, metaxolol, metoprolol, esmolol, and nebivolol. Nebivolol is the generic of Bistolic, which is what patients are used to calling it since it just went generic within the last year or two. But that's kind of what I recommended with her. I didn't want her to have an asthma exacerbation. Okay. All right, Pharmacist Interventions Part 10. Another intervention that I make for some patients are patients picking up fluoroquinolones, usually elderly patients because they're more at risk for side effects. Ciprofloxacin, levofloxacin medications like this are used for bacterial infections, namely UTIs, maybe sort of respiratory infections, skin infections, spontaneous bacterial peritonitis, stuff like that. So they have a lot of warnings with them. They have a risk for CNS effects, confusion, sort of dizziness, peripheral neuropathy, and then tendon rupture. Tendon rupture is very dangerous. You need to stop it if you have pain in your, I guess, tendons, like your ankle. The risk goes up with age and also with concomitant steroid usage. The FDA issued a safety warning due to the risks with the antibiotic, stating that it should be reserved for patients that have no other treatment options. So this intervention that I make is specifically for patients who are like first-time users of this. This is usually from teledoctors for like UTIs. So there's no culture, there's no sensitivity, it's just thrown first line. So I counsel them on the side effects and possibly maybe considering a safer option. Another intervention that I make a lot is for patients who pick up clopidogrel, which is Plavix. It's an antiplatelet. It's used for secondary prevention after someone's had a stroke, to prevent recurring stroke, and then also it's used after someone's had a myocardial infarction and a heart attack, and say they had a STEMI and they got a stent. It's recommended to be on an antiplatelet for a year per AHA or American Heart Association guidelines. So this is for those patients that are picking up this and Prilosec or omeprazole. Omeprazole is an acid suppressor. It's used for GERD, Barrett's esophagus, acid reflux, supposedly short term. But it is a CYP2C19 inhibitor. So it inhibits the enzyme that clopidogrel uses to get oxidized to the active form. This active form over here is the actual structure that via the thiol group binds to where it needs to go to block the receptor and sort of inhibit platelet aggregation. So if you take Prilosec, or for patients who have a polymorphism, a genetic polymorphism of 2C19 who are poorly functioning or underfunctioning, they should be well aware of this interaction. So I recommend maybe switching to something like Protonix that is not as heavily CYP mediated through that same enzyme. A third intervention that I make is for patients who are scared to inject their Lopinox. I'll do that for them. I had a pregnant patient who's terrified of needles. I told her, like, come in every day. I'll give it to you every day. She came 2 days in a row, and eventually I taught her caregiver how to administer those injections. That's a third intervention that I make.